need really, or which are the evidence now for noisy ventilation. We show you the background from experimental study and a very recent patient study. So first of all, a great thank to Professor Marcelo Gama-Debreu from Dresden, who developed most of the technology, and I worked with him since many years, as well as from Patricia Rockberry, where we did many experimental studies on this topic. So the rationale for variable ventilation is in all animals, including humans. Breathing is not constant. You see here a hold here, and you see very variable ventilation. This is the CO2 release during spontaneous breathing. And sedation and disease reduce usually the intrinsic variability of breathing. What is the variability? We have two kinds of variability. One is the variability according to the Gaussian curve, as you can see here, and this is a stochastic and a random. Then we have another kind of variability which follows the power law, which is deterministic and non-random, which does not follow exactly a Gaussian curve. So the different ventilators and different researchers implemented or one or the other type of variability, but data suggests that there is not much different in how the variability is delivered. The issue here is that during constant ventilation of low tidal volume ventilation, you have a constant inflation in the lung. The variable ventilation is associated with some very high tidal volume, which can be, of course, injurious to the lung, and very low tidal volume, even below the conventional limits. The issue is that if we ventilate constantly at high tidal volume, we know that we injure the lung. If we constantly ventilate with very, very low tidal volume, we don't know exactly what can happen, perhaps it also induce some lung injury. The issue is that if we perform just a few breaths according to the Gaussian curve or the power curve on high tidal volume or low tidal volume, is this effective for the lung or not on the physiology and on ventilator-induced lung injury? These are, don't want to enter too much into the detail, but if you want to look at this paper, this is a paper in which we look at the response, biological response of cells in different conditions when they are stimulated with LPS or without LPS, and we stretch these cells with no stretching, with variable stretching, and no variable stretching. And what we found was that there was less response in terms of inflammation, activation inflammation of the cells, when the cells were variable stretched as compared to non-variable stretch. And also we tried to define the biological mechanism leading to that, which probably includes the ERK-1 casting. So the cells by itself has a different response when it is stretched in a variable or non-variable way. Experimental evidence from controlled mechanical ventilation and variable ventilation, controlled variable ventilation. You see here one of the prototype. This is the different volume which is delivered with a different pressure in a constant flow. Of course, the different variable is given by different inspiratory time for breath according to the Gaussian curve, as I showed you before. So you have a variable tidal volume and variable inspiratory pressure. Some of them are very high, some of them are very low. And this is one of the recent study, which you can see here. This is the damage score in the non-ventilated animal with lung injury. And this is variability 30, variability 15, variability 7.5. This is the normal control of ventilation. And you see here that the best results in terms of to minimize ventilator-induced lung injury, we found around 30% of variability, which is more or less the physiological variability. And this was also associated, this is the change in the elastance of the respiratory system, and you see that those animals were ventilated with a variable ventilation with 30%, they have a reduction in the elastance of the rescue system, so improvement in compliance, as compared to the animals ventilated in the conventional way, or less variability. So 30% in control appears to be good. The other issue is how is the perfusion with controlled noisy ventilation. This is another study that we did some years ago in the baseline, injury, and 6 hours of mechanical ventilation. And this is the regional perfusion according to the RDS-net or RDS-net plus noisy. And you see that what we found, there was an increase in the perfusion in the dependent part of the line when we ventilated with noisy ventilation. So there's a higher perfusion, likely with higher amount of recruitment in non-dependent. So the mechanism for improvement in oxygenation during noisy control mechanical ventilation is recruitment in the dependent part with more regional perfusion. When we look at the lung damage in controlled variable ventilation, this is the RDS-net, this is the RDS-net noisy, you see we found overall a reduction in the lung damage, and this was mainly in the dependent part of the lung, but also partially in the non-dependent part. This is not so easy because this recent experiment showed in the RDS pulmonary model and the extrapulmonary model that the effect of variable ventilation as compared to controlled ventilation on interleukin-6 in this case, or procollagen type 3 fibrogenic marker, is mainly in the pulmonary RDS but not in extrapulmonary RDS. So even the type of the lesion of the alveolar capillary barrier may have an effect on how variable ventilation may induce or not ventilator-induced lung injury. This is also a recent study in which we look at the effect of inflammation in a model of pneumonia, so pulmonary RDS, and you see again we found a protection in interleukin-6 in the lung, for example, with variable ventilation we use, and this was not associated with an increase in the bacterial translocation, as you can see here. So in pulmonary RDS, in the experimental model, appears to be more effective than in extrapulmonary RDS. So variable assisted ventilation is a bit different. So this is the variability that you can have during pressure support. So as you can see here, during constant pressure support, variability of respiratory rate is very low, and there is also a reduced variability of volume. So if you have a variable pressure support, you see here, is associated with a variable tidal volume during pressure support. And again, we look at the optimal variation for pressure support, and you see that in this study, as in control mechanical ventilation, we found that during pressure support, the best variability was around 30%. But the mechanisms for improvement in oxygenation during variable pressure support were different as compared to control mechanical ventilation. You see here that when we applied variable pressure support, there was no change. In red are the non-aerated area. These are poorly aerated and non-aerated. So there was no recruitment. This is different from controlled variable ventilation. While we found a redistribution towards the upper part of the lung of the perfusion. So what happens in variable pressure support is that the improvement in oxygenation is not due to the recruitment, at least in our experiments, but is due to a redistribution of perfusion. While in controlled variable ventilation is likely due to the recruitment of the dependent part with redistribution of perfusion towards the dependent part of the line. And also when we look at the damage, this in the control mechanical ventilation and pressure support or noisy pressure support, we found again a reduction in lung damage during pressure support or noisy pressure support. But we did not find any major difference between variable pressure support and pressure support, conventional pressure support. This was also associated with a reduction of interleukin-6 in the lung and many other mediators. Now, which is the clinical evidence for variable pressure, variable control mechanical ventilation and pressure support? In variable control mechanical ventilation, there are no studies in patients. While there is only one study, which is this one, in patients during surgery. These are the trials. So we randomized the patients during abdominal surgery to variable control mechanical ventilation and conventional ventilation, protected ventilation, with a PEEP level of 5. So the only change was variable ventilation. And the study was published now also on VGA. And the primary outcome was the pulmonary function test at the postoperative day 1. But as you can see here, we found a reduction in FEV1 at the day 1 with a partial recovery after day 3. But there was no difference in pulmonary function test, as well as in oxygenation and many other parameters, between variable control ventilation and conventional ventilation. So we were not able to find any positive effects after surgery when we applied variable ventilation during surgery. And this is the first study in patients. What about variable pressure support? Here we have a little bit more information. This is a study that we performed a few years ago in a small group of patients, 13 patients with semi-respiratory, post-operative respiratory failure, with pressure support titrated to reach a tidal volume of 8 liters per kilogram body weight. And as you can see here, the baseline, the conventional pressure support and variable pressure support. The variation of tidal volume, the coefficient variation, increased as expected when we use noisy pressure support as compared to baseline or traditional pressure support. So really the machine is doing this job. In this particular study, we look at the asynchronous, and you see here we look at the ineffective triggering, double triggering, and double effort. And what we found, that noisy pressure support in a very limited period of time was associated with a reduction in patient ventilator asynchronous and mainly double effort as compared to conventional pressure support. So there was an indication, very preliminary, that noisy pressure support was associated with a reduction in asynchronous as compared to conventional pressure support. We recently performed a larger study on 20 patients with mild to moderate RDS. They were studied a bit later in the phase of the disease, around 7 days. And the pressure support again was titrated to reach a tidal volume of around 8 liters per kilogram. And this is the variability at 0, this is the setting, 0, 15, or 30 of pressure support and tidal volume. And you see first that the coefficient of variability is very similar to what is set on the ventilator. 0%, 15%, 30%. But you can see here the range of variability is very different for pressure support and tidal volume. This is the main outcome. This is the first study. It's a 0 variability of pressure support, 15% variability, and 30% variability. As you can see here, a quite large range of PO2 and FiO2 in the patients. And we did not find any effect on average according to the variability of pressure support. And this is the first study in humans. You see that some patients improved PO2 and FiO2, other patients decreased PO2 and FiO2. So it's just independent from the patients. We have to understand more why some patients improved and others did not. What about just briefly pressure time product? Again, we don't find any difference. But again, there are some patients that you can see here, they have a major reduction in the inspiratory effort with variable pressure support, and other patients showed an increase in pressure support. So very individual response to the variability, imposed variability of the respiratory pattern. Then we have a second part of the study, and just I showed you PO2 and PTP just to summarize the concept. Again, the PO2 FiO2 is a study in which we have the baseline pressure support, and the baseline, which is around 10 centimeters of water. Then baseline plus 30% variability. Then reduction of pressure support minus 5 centimeters of water. And adding variability. So we wanted to see if the variability may have a different effect when you are reducing the pressure support, so it can be more effective during a weaning phase. And again, as you can see here, in quite large population of patients, we did not find any effect and of variability both at baseline pressure support, but even when we reduce the level of pressure support. And interestingly here, also pressure type product, we found of course an increase in pressure type product. The time of registration was 1 hour per step. So we analyzed all the breath for 1 hour. You see there was of course an increase when we reduced the pressure support, but there was no effect of variability gain on pressure type product. And there is another study which is finished, is a randomized trial in which we compare the variable pressure support with conventional pressure support on winning success, and this is the protocol published, and the data are analyzed. So to conclude, I show you the biological system show complex variability. The optimal variability of tidal volume appears to be 20 to 30%. The variability of breathing during control mechanism pressure support further improve respiratory function and reduce VLI in experimental RDS model, but there are different effects on the type of RDS. There are different mechanisms between variable and pressure, variable control and pressure support. The preliminary data suggests that variable pressure control does not improve intra and postoperative respiratory function, and variable pressure support does not improve respiratory function in RDS, but the effects are different in each individual patient. The effects of variable ventilation on VLI prevention and winning, which is another issue, apart from gas exchange and inspiratory effort, must be, of course, further investigated, and clinical studies are warranted.